Welcome to the deep dive. Today, we're plunging into a really critical medical procedure, rapid sequence intubation or RSI.
Yeah, this is arguably one of the highest stakes moments in emergency medicine.
Mm.
Securing a patient's airway, often when they're crashing, seconds truly count.
Exactly. And you've handed us a stack of sources, articles, research notes, asking us to really unpack the how and why of this procedure,
Right.
focusing specifically on those crucial medications involved. And you also wanted to understand the absolutely integral role the emergency department pharmacist plays in this, well, pretty intense environment.
It really is. It's a procedure that relies on a very precise chemical sequence, and it has to happen like flawlessly under immense pressure.
Yeah.
Our sources sort of give us the playbook for that.
Okay, so our mission for this deep dive is to cut through the complexity of that playbook, maybe extract the most important nuggets of knowledge about these powerful medications, and show you exactly why choosing the right drug combination at the right time isn't just important, it's, well, vital for getting that tube in safely and successfully.
It's really about understanding the tools, the drugs, and how they interact with the specific patient you have right in front of you.
Okay, let's unpack this then. So, at its heart, what defines rapid sequence intubation? How is it different from just, a regular intubation?
Well, think of standard intubation as potentially having a bit more breathing room. Sometimes you might use mask ventilation, bagging the patient to help along the way.
Mhm.
RSI is designed differently.
Okay.
It's a specific rapid process to quickly secure the airway. The core idea is lightning-fast administration of a sedative induction agent,
Right.
immediately followed by a paralytic agent.
And that immediately followed is the defining feature, isn't it? Because once those drugs go in, there's no mask ventilation performed in RSI.
Precisely. You are intentionally skipping that step. You're committing to getting the tube in right then because you need to prevent something specific from happening.
Which leads to the why. Why use this rapid, no mask ventilation approach? What kind of patient needs this?
Well, the main reason, and this is highlighted across our sources, is to minimize the risk of aspiration.
Ah.
Yeah, imagine a patient who needs intubation but has a full stomach, maybe from trauma, an obstruction, or even just recent eating. Mask ventilation could actually push stomach contents down into the lungs.
Right, that's bad.
Very bad. So RSI is key for those folks at high aspiration risk. Or, frankly, anyone where you anticipate a potentially difficult intubation, where bagging might cause issues, or in situations where the airway is just rapidly deteriorating or gas exchange is severely impaired.
Got it. Speed and preventing aspiration. Okay. Now, our sources mention the 7Ps as a sort of handy framework for the whole intubation process, preparation, pre-oxygenation, and so on.
Right, it's good mnemonic.
But for this deep dive, we're really focusing on where the pharmacology shines.
Yeah.
Two key steps, pre-treatment and then paralysis with induction.
Exactly. And that's where the emergency department pharmacist steps onto the stage as an absolutely crucial team member.
How do they contribute in such a high-pressure, fast-moving situation? I mean, it feels like it could be chaos sometimes.
Oh, it absolutely can be chaotic. And that's precisely why the pharmacist's expertise is so invaluable. They aren't just, dispensing drugs from the pikes.
Right.
They're part of the critical thinking team. They can help identify patients who might benefit from specific pre-treatment based on their medical history or current state.
Okay.
They are vital in selecting the right induction and paralytic agents and the right doses for that specific patient, considering all their underlying conditions. And they're already thinking ahead about the post-intubation sedation plan.
So in that relative chaos, they're kind of the go-to expert for building the optimal drug plan on the fly.
Exactly. And not just the optimal plan A, but having contingency plans, plan B, plan C ready to go. Because things don't always go perfectly smoothly.
Sure.
They need to anticipate potential complications based on the drugs being used and the patient's own physiology.
Okay, let's jump into step 3 then, pre-treatment. What's the goal here? Giving drugs before the main event, the induction and paralysis.
The purpose is basically to put up a shield. You're trying to attenuate or blunt the body's involuntary negative responses to having a laryngoscope
Well,
shoved down your throat.
right, that can't feel good. What kind of responses are we trying to blunt exactly?
Well, laryngoscopy is stimulating. It triggers nerves in the airway, leading to these sympathetic and parasympathetic surges.
Okay, so what does that mean practically?
Think spikes in heart rate and blood pressure. That's really dangerous for patients who already have heart issues or maybe brain injuries. It can also cause laryngospasm, bronchospasm, coughing. Pre-treatment aims to minimize all those reflex responses.
And the sources say these pretreatment agents are typically given, what, a few minutes before? Like 3 minutes?
That's the ideal timing, yeah.
Yeah.
About 3 minutes before the main induction and paralytic agents. That lets them get to work. But, in a true crash scenario, that window might get compressed. Or even skipped entirely, depending on how urgent things are.
Okay, let's walk through some of the specific pretreatment agents our sources cover. First up, fentanyl.
Okay, fentanyl. It's a synthetic opioid. Its main job here is to help blunt that sympathetic surge we just talked about, the increase in heart rate and blood pressure caused by the intubation stimulus.
Why fentanyl specifically? What makes it good for this?
Well, its properties are pretty ideal for RSI. It's highly lipophilic, which means it gets into the brain and works really fast.
Ah.
And it has a relatively short duration of action, which is exactly what you want for a quick procedure like this.
And the dose. And who is it most important for? Like, who really needs this blunting effect?
A typical dose is about 1 to 3 micrograms per kilogram, given ideally 3 minutes prior. It's particularly important in patients where a sudden spike in blood pressure or heart rate could be, well, disastrous.
Like who?
Think patients with poor cerebral autoregulation, maybe someone with a head injury, or someone with acute ischemic heart disease, or maybe an aortic aneurysm or dissection. You really want to avoid stressing those systems.
Makes total sense. Protecting those vulnerable organs from those big hemodynamic swings. Any key side effects to watch out for with fentanyl?
The main concern is respiratory depression, obviously. But giving the dose slowly, say over 30 to 60 seconds, helps mitigate that risk quite a bit. Very large doses rarely can cause chest wall rigidity, sometimes called wooden chest.
Okay. How about lidocaine? That's another common one mentioned in the sources for pretreatment.
Yeah, lidocaine. It's been used for several potential benefits in pretreatment. Historically, the thinking was it could help blunt the sympathetic response too, maybe raise the seizure threshold, decrease cough, and potentially inhibit bronchospasm, which is obviously key in patients with reactive airway disease like asthma.
And the proposed mechanisms are a bit fuzzy, right? Something about suppressing reflexes, helping GABA, stabilizing membranes.
Right. There are multiple theories about exactly how it might work. Now, here's where it gets really interesting with lidocaine.
Oh, okay. Diving into the nuance. I like it.
The actual clinical evidence for lidocaine's effectiveness in these roles is, well, conflicting, according to our sources anyway.
How so?
For example, some studies suggest it helps blunt the increase in intracranial pressure, the ICP, during intubation. But others show the ICP still increases, just maybe not quite as much. Similarly, studies on its ability to actually prevent bronchospasm during intubation have had pretty mixed results.
So despite these kind of conflicting study results, it's still widely used.
It is, yeah. It's still common practice in many places. The typical dose is 1.5 milligrams per kilogram, but again, that 3-minute wait time for pretreatment might just not be feasible in a truly crashed situation.
What about side effects for lidocaine? Any big ones?
The biggest one to consider is probably hypotension, low blood pressure. That's especially concerning in patients with head injuries because maintaining good blood pressure is absolutely vital for brain perfusion.
Right.
There's also a risk of arrhythmia, and you have to be aware of potential interactions with certain heart medications like dronedarone or amiodarone.
Okay. Next up, atropine. Now, that feels more like something you'd use in kids during intubation, right? To prevent bradycardia.
You're absolutely right. You see it most often in pediatrics to prevent bradycardia, that slowing of the heart rate. It's a more common vagal response in children during intubation. However, it definitely can happen in adults too.
What makes an adult more likely to need atropine pretreatment then?
Well, adults who are already on medications that slow the heart rate, think beta blockers, calcium channel blockers, maybe amiodarone or digoxin.
Okay.
Or if you're giving fentanyl as part of your RSI cocktail, since fentanyl itself can have some vagal effects. In those cases, they might benefit from atropine to prevent a significant drop in heart rate. The adult dose is 0.01 milligrams per kilogram.
Side effects. Pretty standard anticholinergic stuff.
Exactly. Fast heart rate, dry mouth, maybe flushing, difficulty urinating. Usual suspects.
And midazolam, I usually think of that as a sedative for procedures like conscious sedation, but it's listed as a pretreatment here. How does that work?
Yeah, as a pretreatment, its primary role isn't deep sedation. It's more about anxiolysis, calming the patient down and providing some amnesia for the procedure. It's a fast-acting benzodiazepine.
What's the typical dose range for that pretreatment use?
Usually pretty low, like 1 to 2 milligrams IV. You'd use a lower dose in older patients because they're generally more sensitive, and potentially a slightly higher dose in patients with significant obesity.
Okay. And how does it work?
It works by enhancing GABA, which is the main inhibitory or calming neurotransmitter in the brain. It gets into the brain quickly because it's highly lipophilic, like fentanyl,
Right.
but doesn't stay there super long. Its effect is relatively short due to redistribution out of the brain. It's metabolized in the liver, but one of its metabolites is active and gets cleared by the kidneys, which is something to keep in mind if you have a patient with kidney problems.
Any significant side effects when used just for this pretreatment purpose?
When used alone at these low doses, usually few significant side effects. But, and this is important, if you combine it with other central nervous system depressants like fentanyl or later the induction agents, you can definitely see additive respiratory depression.
Okay.
Our sources suggest it's often considered the preferred benzo for RSI pre-medication, though, because of its quick action and good amnesic properties.
Finally, phenylephrine. That's a vasopressor, right? A drug to raise blood pressure. Why is it listed under pretreatment?
Good catch. Phenylephrine isn't given to blunt the intubation response itself, like the others. It's listed here because it's a drug you might need ready or even give preemptively.
Ah, okay.
To treat hypotension that could result from giving the other pre-medications, like lidocaine or fentanyl, or later from the induction agents, some of which can drop blood pressure.
So it's just sort of in the category because it might be used around that specific time to support blood pressure if needed.
Exactly. It's a quick onset, quick offset pressor. A common dose is maybe 50 to 200 micrograms IV push. The main side effect to watch for is reflex bradycardia. The heart rate slowing down because the blood pressure has gone up.
Okay, that lays out the pretreatment options pretty clearly. Now, the core of RSI, step 4, paralysis with induction. This is the rapid part, the main event.
This is absolutely the core. This is where you give the sedative induction agent, immediately followed by the paralytic agent, and let's be crystal clear about the order.
Wow.
The sedative induction agent always comes first.
Yeah.
Every single time. Non-negotiable.
Why is that order so absolutely critical? What happens if you get it wrong?
The risk is, well, it's severe. If you give the paralytic first, the patient becomes completely unable to move, unable to breathe, unable to signal distress in any way, but they are still awake.
Oh, wow.
They are fully conscious, completely aware, but trapped in their own body during the entire, potentially very unpleasant procedure. Our sources emphasize this dramatically increases the risk of significant psychological trauma like post-traumatic stress disorder.
Yeah.
This is a key safety check where an experienced pharmacist or clinician can and should intervene, especially if working with newer staff or in a chaotic situation.
That is a truly chilling thought. So, okay, the induction agent provides the anesthesia, puts them completely to sleep, makes them unaware,
Right.
and the paralytic gives you the muscle relaxation you need to actually get the tube in easily.
Precisely. The induction agent produces general anesthesia. The paralytic, the neuromuscular blocking agent, or NMBA, provides the ideal intubating conditions by paralyzing the skeletal muscles, including the vocal cords and jaw muscles. But, and this is a huge but you must remember, the paralytics themselves provide absolutely no sedation, no amnesia, and no analgesia. Zero.
Okay.
Giving a paralytic without ensuring the patient is adequately sedated first is simply inhumane and unacceptable.
And once you give that paralytic, you've basically committed, you have to secure that airway, right?
Absolutely. You must be fully prepared for a difficult airway or even a failed airway scenario. Because depending on the paralytic used, the patient may be unable to breathe on their own for anywhere from, say, 10 minutes to potentially over an hour.
Wow.
So if you can't get the tube in quickly, you must be able to successfully bag mask, ventilate the patient to keep them oxygenated. Or if that fails too, you need to be ready to proceed immediately to a surgical airway, like a cricothyrotomy.
Okay. High stakes indeed. Let's look at the induction agents first. Etomidate is often called the gold standard, isn't it? Why is that?
It is, yeah. And primarily because of its hemodynamic profile. It's known for being very stable in terms of blood pressure and heart rate.
Okay.
Etomidate is a sedative hypnotic. It puts people to sleep. And it does this by enhancing the effects of GABA in the brain. The typical dose is 0.3 milligrams per kilogram of the feet.
Any dose adjustments?
You might consider going a little lower, maybe 0.2 milligkilograms in patients who are already very hemodynamically unstable, like hypotensive. And for patients with morbid obesity, using adjusted body weight is often recommended for dosing.
How fast does it work and how long does it last? That's key for RSI.
Very rapid onset, typically 10 to 15 seconds, which is perfect for RSI. You want them unconscious fast, and its duration is relatively short, around 4 to 10 minutes.
What are its big advantages besides being fast and hemodynamically stable.
It's particularly excellent for patients with brain injuries. It decreases cerebral blood flow and the brain's metabolic rate, and it effectively attenuates or lowers elevated intracranial pressure, ICP, so it helps protect the brain.
But there's a significant debate, a controversy really, with etomidate, isn't there? Something about adrenal suppression.
Yes, that's the big one. Adrenal suppression is a known effect. Etomidate inhibits an enzyme called 11-beta-hydroxylase, which is needed to make cortisol, the body's main stress hormone. The big debate, swirling for years now, is whether this transient biochemical effect, the drop in cortisol levels, actually translates into worse clinical outcomes, particularly increased mortality, especially in critically ill patients like those in septic shock.
And what do the sources say? Is there a link?
Well, it's messy. Some studies, including some meta-analyses, have suggested an association between etomidate use and increased mortality in sepsis. But other large studies and subgroup analyses have found no such link when comparing it to alternatives like ketamine.
So, based on the sources we looked at, there isn't really a clear consensus on whether you should absolutely avoid it if you suspect someone might have adrenal insufficiency.
That's right. The evidence base is conflicting, and our sources don't provide a definitive recommendation to either always use it or always avoid it in patients where adrenal insufficiency is a strong concern. It remains a point of clinical judgment and ongoing debate.
Okay. Any other notable side effects of etomidate we should mention?
You can sometimes see myoclonus, which are these brief involuntary muscle jerks. It can look a bit like a seizure, but it's generally benign in this context and stops once the paralytic kicks in.
Yeah.
There can be pain on injection, which is often due to the propylene glycol diluent. Postoperative nausea and vomiting can occur. It causes a moderate reduction in intraocular pressure. And there's some caution advised in patients with seizure disorders, as it might lower the threshold for focal seizures, although it might potentially raise it for generalized seizures. It's complex.
Okay. Next up, ketamine. This one feels really different from the others, doesn't it?
It absolutely is. Ketamine is quite unique among the induction agents we're discussing because it provides both profound anesthesia and significant analgesia pain relief. The others don't really do that.
How does it work?
It works differently, too. It's a non-competitive NMDA receptor antagonist. You might have heard of NMDA receptors in relation to memory and pain.
And it puts people in that strange cataleptic state, right?
Right.
Dissociative anesthesia.
Yes, exactly. Characterized by open eyes, sometimes a slow, nice dagmoid gaze, muscle rigidity but preserved airway reflexes sometimes. It also provides dose-related amnesia, though maybe not quite as complete as you get with benzodiazepines.
What's the induction dose for RSI?
Typically 1 to 2 milligram per kilogram IVM. A common adult dose might be around 100 milligram. If you absolutely have no IV access and it's life-threatening, you can give it IM, but the dose is much higher, 4 to 10 milligrams per kilogram, and the onset is much, much slower. Not ideal for RSI if avoidable.
Onset and duration 5.
Very rapid IV onset, usually around 30 seconds. And the duration is about 5 to 15 minutes. It's metabolized in the liver to an inactive metabolite that's then cleared by the kidneys.
Okay, so what are the clinical scenarios where ketamine really shines? Where would you pick it over etomidate, for example?
Well, what's fascinating here, and really its main advantage, is its effect on the cardiovascular system. It's generally sympathomimetic, meaning it tends to increase heart rate, blood pressure, and cardiac output. It does this largely by stimulating the central nervous system's sympathetic outflow and blocking the reuptake of catecholamines like adrenaline.
Ah, so it supports blood pressure.
Exactly. This makes it an excellent choice for patients who are hypotensive, volume depleted, or otherwise hemodynamically unstable. It can actually help stabilize them during the induction phase. You might cap the dose around 1.5 mg AD in patients who you suspect are already severely catecholamine depleted, though.
So if you're worried about the patient crashing hemodynamically during intubation, ketamine is often a really good option.
Precisely. And there's another big plus. It's a bronchodilator. It relaxes bronchial smooth muscle.
Oh, interesting.
Yeah, which is incredibly beneficial in patients with reactive airway disease or severe asthma who need intubation. It can actually help open their airways.
Now, there used to be a lot of concern, maybe even dogma, about ketamine increasing ICP, especially in head injuries. Has that thinking changed based on the sources?
That's another area where newer evidence has been really important, yes. While there was definitely historical concern about increased ICP, more recent studies, particularly in patients who are already sedated and mechanically ventilated, have shown that ketamine doesn't seem to significantly increase ICP.
Really?
Yeah, and perhaps more importantly, it helps maintain mean arterial pressure, MAP, and therefore cerebral perfusion pressure, CTP, which, as we discussed with lidocaine and blood pressure, is absolutely vital in head-injured patients.
So despite that old concern, it might actually be a good choice in a hypotensive head-injured patient needing RSI.
Exactly, because maintaining adequate blood pressure to perfuse the injured brain is paramount. However, there's a caveat. In patients who are severely catecholamine depleted, like maybe end-stage shock or those with severe heart failure, ketamine's direct effect on the heart muscle can actually be a negative inotrope, meaning it weakens contractions. In those rare cases, it could potentially worsen hypotension or myocardial depression.
Okay. Good nuance there. Any other side effects we need to know about?
Increased oral secretions, like salivation, can occur, although it's typically not clinically significant within the short time frame of RSI itself. And then there are the classic side effects people worry about as the patient wakes up. Emergent delirium, vivid dreams, nightmares, hallucinations.
Right, the emergence reaction. I've heard giving a benzodiazepine beforehand, like midazolam, might prevent those issues. Is that recommended?
Our sources discuss this. There's definitely been a debate about using prophylactic benzos. However, recent studies seem to suggest that giving a benzo beforehand doesn't reliably prevent these emergence reactions.
Oh.
And importantly, it does seem to increase the risk of respiratory depression and prolongs the recovery time. So based on that, it's generally not a standard recommendation anymore just to prevent emergence phenomena.
Interesting. Okay, let's move on to propofol. It's so widely used for sedation everywhere else in the hospital. How does it fit into RSI?
Propofol is definitely another common induction agent used for RSI. It's a highly lipid-soluble phenolic derivative. And like etomidate and midazolam, it works primarily by enhancing the effects of GABA.
What's the typical induction dose for RSI?
Usually around 1.5 milligrams per kilogram IV in healthy patients. You typically use actual body weight in obese patients. But, and this is key, you definitely use a lower dose, maybe just 50 to 100 milligrams total in elderly patients or the critically ill because they have decreased clearance and a smaller volume of distribution. They're much more sensitive to its effects.
Onset and duration. Needs to be fast for RSI.
Very rapid onset, yeah. About 15 to 45 seconds, and relatively short duration, 5 to 10 minutes. It's metabolized primarily in the liver, which generally makes it a suitable option even for patients with kidney or moderate liver impairment.
What are the main advantages of propofol for RSI?
It's very effective at decreasing ICP, intracranial pressure. That's a big plus in patients with head injuries, similar to etomidate, but maybe even more pronounced. It also has some mild bronchodilating effects, which can be helpful in patients with bronchospasm. Unlike ketamine, though, it provides absolutely no analgesia, no pain relief. It's also listed as Category B for pregnant women.
And its most notorious side effect, the one everyone worries about.
Hypotension. Definitely hypotension. It causes a dose-related decrease in systemic vascular resistance, meaning it relaxes blood vessels, and also direct myocardial depression. It slows the heart muscle down a bit.
Okay.
This effect can be amplified and quite profound in critically ill patients, especially those who are already volume depleted or have impaired heart function. It's the main reason you have to be really cautious using it or use much lower doses in hemodynamically unstable patients.
And the pain on injection, is that common?
Very common, yes. Using a larger vein helps, or sometimes administering a small amount of lidocaine beforehand or concurrently with a propofol infusion can help attenuate that burning sensation.
And that classic egg allergy warning with propofol, is that a real contraindication?
Yeah, our sources clarify this nicely. They explain it's likely not a true contraindication for most people with egg allergy. The significant egg allergens are typically proteins found in the egg white.
Right.
But propofol contains egg lecithin, which is derived from the egg yolk. While theoretically possible, severe reactions are thought to be very rare. When allergic-type reactions do occur with propofol, they're more likely due to the propofol molecule itself, not the tiny amount of egg yolk component. So a history of egg allergy is generally not considered an absolute contraindication anymore.
Good to know. That comes up a lot. Okay, what about methotrexate? That one seems less common.
Methotrexate is a short-acting barbiturate. It's sometimes used as an alternative induction agent, particularly since thiopental, another barbiturate that was historically used quite a bit for RSI, is no longer available in the U.S. It's also a GABA agonist, like propofol and etomidate.
Dose, onset, duration.
The dose is around 1.5 milligrams per kilogram IVV. Onset is fast, less than 30 seconds, and duration is similar to propofol, about 5 to 10 minutes. It's metabolized by the liver, no active metabolites.
Side effects. What are the concerns with methotrexate?
Like other barbiturates, it can cause significant respiratory depression. It also causes venodilation and myocardial depression, which means it can lower blood pressure.
Okay, so similar hemodynamic concerns as propofol.
Yes, exactly. Which means you generally want to avoid it in patients who are already hypotensive or in patients with head injuries where maintaining blood pressure is critical. It does decrease cerebral metabolic oxygen demand in ICP, similar to propofol again, but that risk of hypotension in head injury is a big consideration.
Anything else?
It can also cause histamine release, which could potentially exacerbate reactive airway disease, and sometimes it causes excitatory symptoms like hiccups or muscle twitching. There's also a risk of distal thrombosis or tissue necrosis if it's accidentally injected into an artery or extravasates outside the vein. Small studies comparing it to etomidate found similar intubation success rates and hemodynamic effects, though.
And midazolam again, but now thinking about using it as the primary induction agent itself.
Yes, though it's generally used less commonly as the primary induction agent in adults for RSI, maybe more often in pediatrics.
Hmm.
If you were to use it for induction, the dose is higher than the pretreatment dose, more like 0.2 to 0.3 milligrams per kilogram by fee.
And how does it perform for the rapid part of RSI compared to the others like etomidate or propofol?
Well, that's the main limitation. When used alone, Wodalalem has a notably slower onset than etomidate or propofol, sometimes taking up to 5 minutes to achieve full effect. And it might result in incomplete loss of consciousness, which really isn't ideal for RSI.
Hmm.
The onset does improve, maybe down to around 90 seconds if you give it concurrently with opioids, but that's still generally slower than preferred compared to the other main induction agents.
And the hemodynamic effects and duration at these higher induction doses?
Similar to propofol, it causes a dose-related decrease in systemic vascular resistance and some myocardial depression. So again, caution is needed in volume-depleted or hemodynamically unstable patients. And because of its properties and that active metabolite we mentioned earlier, you'd expect more prolonged sedative effect compared to etomidate or propofol, especially in elderly patients or those with significant heart failure or liver disease. Generally, it's considered less optimal for the speed and reliability required for emergent RSI when used as the sole induction agent.
And just to circle back one last time on phenylephrine here.
Correct. Just mentioning it again in this section to reinforce its role as a drug you might need ready or use concurrently to manage hypotension caused by any of these induction agents, particularly propofol or maybe ketamine in those susceptible patients we discussed. It's part of the supportive care around induction.
Okay, that covers the induction agents in detail. Now let's move to the other half of the core RSI step, the neuromuscular blocking agents, the paralytics that provide those crucial intubating conditions. Succinylcholine is often mentioned first, the classic agent.
Succinylcholine is unique. It's the only highly depolarizing neuromuscular blocking agent available in the U.S. And for many, many years, it was absolutely considered the gold standard for paralysis in RSI. Still is by some.
Why the gold standard reputation? What makes it so good for RSI?
Primarily because of its extremely rapid onset and predictably short duration of action. It works differently than the others. It mimics acetylcholine at the neuromuscular junction, causing sustained depolarization of the muscle membrane. This leads to initial brief muscle twitching. Those are called fasciculations, which you can often see, followed quickly by profound paralysis. It also stimulates some autonomic receptors.
What's the typical dose and how fast does it really work?
The standard IV dose is 1.5 milligrams per kilogram. And it's recommended to use actual body weight. Even in obese patients, don't underdose it. If you have to guess the weight, overestimate slightly.
Okay.
The onset is lightning fast, typically within 45 seconds. You see the fasciculations, then relaxation. And the duration is reliably short, around 10 minutes usually.
What about IM?
If you absolutely cannot get IV access in a life-threatening emergency, you can give it IM at a higher dose, 4 milligrams, with a max of 150 milligrams, and this is big, but the onset is significantly delayed and less predictable, maybe 5-6 minutes, perhaps 2-3 minutes sometimes. That delay increases the risk substantially if you can't intubate or ventilate during that time. 4 is strongly preferred.
And its short duration is because it's broken down so quickly in the body.
Yes, exactly. It's rapidly hydrolyzed, chewed up, by an enzyme in the blood called plasma cholinesterase or pseudocholinesterase. However, a small percentage of the population has a genetic deficiency in this enzyme.
And what happens then?
They can have dramatically prolonged paralysis after a standard dose of succinylcholine, potentially lasting 6 to 8 hours instead of 10 minutes. That's obviously a major issue if you weren't expecting it.
Wow. Okay. Now, succinylcholine seems to come with a pretty significant list of potential adverse effects and contraindications. Malignant hyperthermia is a big one, right?
Yes, it's a well-known triggering agent for malignant hyperthermia. MH, which is a rare but potentially life-threatening hypermetabolic reaction in susceptible individuals.
What were the signs?
You'd watch for classic signs like a sudden, unexplained rise in body temperature, a rapid increase in end-tidal CO2 monitoring, unexplained tachycardia, fast heart rate, and muscle rigidity, which can include masseter muscle rigidity or jaw tightness. It's a critical emergency if it occurs.
And hyperkalemia, high potassium is another major concern, sometimes dangerously so. Can you unpack that?
This is absolutely crucial to understand. Succinylcholine typically causes only a small, clinically insignificant rise in serum potassium in most patients, usually around 0.5 to 1 MEQL. So importantly, it's not generally contraindicated in patients with acute hyperkalemia from conditions like diabetic ketoacidosis, DKA, or acute renal failure. In those situations, you'd only expect that small, manageable rise.
But there are specific patient groups where the risk of a massive, life-threatening potassium spike is very real.
Yes, this is the key clinical takeaway. The significant, dangerous rise in potassium, potentially 5 to 15 millieql, which can cause cardiac arrest, occurs in patients who have conditions that cause an upregulation or proliferation of extrajunctional cholinergic receptors in their skeletal muscles. These receptors are usually only at the nerve junction, but they spread out across the muscle membrane in certain states.
And what conditions cause that?
This is seen in patients with prolonged immobilization, like weeks in the ICU, severe crush injuries, major burns after the first 24-48 hours, certain inherited muscle diseases like muscular dystrophies, and importantly, denervating diseases or injuries.
Like a severe stroke or a spinal cord injury?
Exactly. Our sources emphasize that this risk of hyperkalemia generally starts about 5 to 15 days after the initial acute nerve injury or stroke happens. But once those extra receptors are present, the risk with succinylcholine can persist for a long time, potentially months or even indefinitely. This is a critical piece of patient history the team absolutely needs to assess before giving succinylcholine.
Wow, okay. That's a huge safety point. What are the other side effects mentioned?
Bradycardia, a slow heart rate, can occur, especially with repeat doses or more commonly in infants and children. Pretreating with atropine can often prevent this. There's also some ongoing debate about its effect on ICP. Some older studies showed a minor transient increase of 5-10 mmHg, while others, particularly more recent ones, show little to no effect, especially if the patient is properly induced.
And eye pressure.
It does cause a transient increase in intraocular pressure, IOP, by about 5 to 10 mmHg for a few minutes. But interestingly, despite this, it's still commonly used even in patients with open globe eye injuries because the risk of actual vitreous extrusion seems to be very rare in practice.
And repeat doses are generally discouraged.
Yes, generally avoided if possible. Cumulative doses over about 6 millikilograms are typically discouraged due to the potential for developing a less predictable type of block called a phase 2 block, which can prolong recovery.
Okay, so succinylcholine. Super fast onset, very short duration, but comes with some significant specific risks you absolutely must screen for. What's the main alternative if you can't or don't want to use succinylcholine?
Rocuronium is the most commonly used alternative. It's a non-depolarizing NMDA. It works differently than succinylcholine. Instead of mimicking acetylcholine, it competitively blocks the acetylcholine receptors at the neuromuscular junction.
Okay.
It's generally considered the closest non-depolarizing match to succinylcholine in terms of achieving rapid intubating conditions relatively quickly.
How does its speed compare? Is it as fast as succinylcholine?
Not quite as fast, but still pretty rapid for RSI purposes. The typical RSI dose is usually higher than its standard dose, around 0.6 to 1.2 milligrams per kilogram IVV. At these doses, its onset is usually around 1 to 2 minutes, so a bit slower than succinylcholine's typical 45 seconds, but often quick enough for most RSI situations.
And the duration, that's a key difference, right?
Yes, this is the major difference from succinylcholine and a critical consideration. Rocuronium's duration of action is significantly longer. Depending on the dose and patient factors, it can range from 30 to maybe even 67 minutes or longer sometimes.
Wow, that's a long time to be paralyzed if things go wrong.
Exactly. This is a critical point. If you anticipate any difficulty with bag mask ventilation or with the intubation itself, that much longer paralysis time means the patient will be apneic, unable to breathe on their own for a much longer period. This needs careful consideration when choosing between succinylcholine and rocuronium.
And how do studies compare rocuronium to succinylcholine head-to-head for RSI? Is one better?
The studies are somewhat mixed, actually. Some studies suggest succinylcholine provides slightly better or faster intubating conditions. Others show no significant difference in key outcomes, like successful first-pass intubation rates or oxygen saturation levels during the procedure, especially when using the higher RSI doses of rocuronium. So practice varies.
Okay. What about vecuronium? Is that used for RSI?
Rocuronium is another non-depolarizing NMDA, works similarly to rocuronium as a competitive inhibitor. The dose is lower, around 0.08 to zero point 0.1 milligrams per kilogram IV.
Is it suitable for the speed needed in emergent RSI?
Generally, no, not as a first-line agent. Its onset is even slower than rocuronium, typically taking 2 to 4 minutes to achieve full paralysis. And its duration is also quite long, maybe 20 to 60 minutes.
Okay.
For this reason, the slower onset compared to succinylcholine or RSI-dosed rocuronium is usually not recommended as a first-line choice for emergent RSI when speed is truly paramount. However, our sources mention it might be necessary sometimes during drug shortages if other agents aren't available.
Speaking of which, are there reversal agents for these paralytics if needed?
Yes, there are. For the non-depolarizing agents like rocuronium and vecuronium, and another one called pancuronium, a specific reversal agent called succinylcholine is mentioned in the sources. It works differently by encapsulating the drug molecule itself and can provide very rapid reversal.
Okay.
For non-depolarizing agents like vecuronium or potentially rocuronium, though it's less ideal for profound block, the older reversal strategy involves using an acetylcholinesterase inhibitor like neostigmine. This works by increasing the amount of acetylcholine available to compete with the blocker. However, neostigmine has significant cholinergic side effects, so it must be co-administered with an anticholinergic agent like glycopyrrolate to counteract those effects, particularly severe bradycardia, and its onset is slower than succinylcholine.
Got it. One last thing on paralytics, I've heard of sometimes giving a tiny dose of a non-depolarizing agent like rocuronium right before giving succinylcholine. What was that about? Defasciculation.
Yes, exactly. That was called a defasciculating dose, or sometimes a priming dose, though priming means something slightly different. The idea behind defasciculation was to give a very small, non-paralyzing dose of a non-depolarizing agent, like 10% of its intubating dose, about a minute before the succinylcholine.
Why?
The theory was that this would prevent or lessen the visible muscle fasciculations caused by succinylcholine. And those fasciculations were thought by some to potentially increase ICP or cause muscle pain later. However, our sources state that this practice is generally no longer routinely recommended.
Why not?
Because subsequent studies haven't really shown a clear benefit in clinically important outcomes, like preventing ICP increases or improving intubating conditions. And giving that small dose could potentially slightly slow the onset or weaken the effect of the succinylcholine or require a slightly higher dose of succinylcholine.
Yeah.
So the risk-benefit didn't really pan out.
Okay, that makes sense. That's a huge amount of detail on the drugs themselves, the induction agents and the paralytics. Let's zoom out a bit now and talk about a very real ongoing challenge that impacts all of this: drug shortages.
Yeah, this is a significant and unfortunately growing problem in healthcare across the board. And it absolutely impacts the availability of these critical RSI medications frequently. You might find your preferred etomidate or succinylcholine is on back order.
So if your usual go-to drug for a specific patient scenario is suddenly unavailable, how does that affect things in a high-pressure RSI situation?
Well, it forces you to make substitutions, obviously, often selecting alternate combinations of induction agents and paralytics.
Right.
And this isn't just, picking the next drug alphabetically on the shelf.
Right.
The selections absolutely must be made based on a deep understanding of the pharmacodynamic properties we've been discussing, how these drugs work, their onset, their duration, their side effects, to avoid potentially dangerous consequences. You have to choose the right alternative for that patient.
What are some examples of problematic or potentially risky combinations that shortages might force clinicians into, as highlighted in the sources?
A major one they flag is the potential mismatch of durations. For example, combining a very short-acting induction agent like propofol, etomidate, or even ketamine with a significantly longer-acting paralytic like rocuronium or vecuronium without having a robust plan for immediate and ongoing sedation after the induction dose wears off.
Which takes us right back to that chilling thought of patient awareness, paralyzed but awake and aware because the sedation wore off way before the paralysis did.
Exactly. It's a huge risk if not managed proactively. Another risk is inadvertently combining drugs that have additive side effects that could harm the patient based on their underlying condition. For instance, using propofol and succinylcholine together in a patient who's already prone to slow heart rates, because both drugs can cause bradycardia. Or maybe methoxetyl and succinylcholine together, both potentially raising ICP, although, as we said, that's debated, which could be bad in head injury. You have to think about the combined effect profile.
And what about reaching for drugs that aren't typically used for RSI at all, just because the standard ones aren't available? Is that ever okay?
The sources caution strongly against this. They emphasize using off-label drugs that simply don't fit the necessary criteria of providing rapid, reliable anesthesia and paralysis, suitable for the specific demands of RSI.
Can you give an example?
Well, they reiterate that a standard planned intubation procedure where you can safely mask ventilate the patient beforehand and maybe take a bit more time is very different from an RSI, where speed and avoiding bagging are key. Drugs that are useful for procedural sedation or ICU sedation, like maybe dexmedetomidine, have a much slower onset and wouldn't provide the necessary rapid loss of consciousness and profound muscle relaxation needed for a true RSI sequence. Using the wrong tool for the job can be dangerous.
This really highlights how these shortages turn an already complex procedure into an even more intricate puzzle sometimes, where that deep drug knowledge is absolutely everything.
Absolutely. And this circles back perfectly to the critical role of the emergency department pharmacist, which you wanted us to focus on. Their expertise in navigating this complex maze of options, considering the specific patient's condition, the unique properties of each available drug, potential side effects, contraindications, drug interactions, and the constantly changing landscape of drug availability due to shortages, is truly vital.
Yeah.
They are the medication experts on the team, making sure the team uses the best possible agents available under immense pressure to ensure a successful intubation and, most importantly, patient safety.
They're essentially the conductors making sure this rapid chemical symphony happens in the right order with the right instruments, even when some of the usual instruments might be missing from the orchestra pit that day.
That's a very apt analogy, yes. They are absolutely key to optimal decision-making in this high-stakes environment.
So we've taken a pretty deep dive today into the critical world of rapid-sequence intubation pharmacology. We've seen how a carefully chosen cocktail of medications works rapidly to silence the body's unwanted responses and create those perfect conditions needed to secure an airway quickly and safely.
Uh-huh.
And we've really seen just how indispensable the emergency department pharmacist's expertise is in navigating these complex choices.
Yeah.
Everything from selecting the right pretreatment, if any, to picking the optimal induction and paralytic agents based on the patient's specific physiology, the drug properties, and increasingly what's even available on the shelf that day.
Yeah. It's become clear, I think, that it's not just about knowing which drug's name to call out in the heat of the moment. It's about deeply understanding the why behind its use for this specific patient.
Right.
Understanding its mechanism, its potential benefits, its significant risks and contraindications, and knowing what the viable alternatives are when your ideal agent just isn't an option. That depth of knowledge is truly what makes the difference in these critical moments.
Okay, here's a final thought for you to consider, building on everything we've discussed today. In a procedure where success and safety are literally measured in seconds and minutes, and where the choice of drug is so absolutely paramount, how does this persistent, unpredictable challenge of drug shortages fundamentally force innovation and adaptation in practice? And maybe more broadly, what does that mean for how critical care teams need to train and prepare for emergent airway management moving forward in an era where drug availability can no longer always be taken for granted?